Hello, and welcome to the lecture on assessment of the abdomen and the GI tract. This is Dr. Sutton. Today we will be covering a lot of information about gastrointestinal system assessment, but also we're going to be covering some information about assessment of the abdomen in general. Remember, there's a lot of organs that are in the abdominal cavity that are not specifically related to the GI tract, which is, remember, mouth to anus. It may also include liver, pancreas, kidneys, uterus, bladder. So we're going to include some of that information in this lecture. First, we're going to cover a review of A&P and landmarks, and I noted on this slide that the pages are 529 to 534 in your textbook. There's also a video posted in Blackboard that is a good review of the gastrointestinal system anatomy and physiology. The internal organs of the abdomen are known as viscera. The organs that maintain a solid shape are solid viscera. These include the liver, pancreas, spleen, adrenal glands, kidneys, ovaries, and uterus. The abdomen is also divided in 4 quadrants: the right upper quadrant, the left upper quadrant, the right lower quadrant, and the left lower quadrant. The location of abdominal structures is often classified by these quadrants. Some structures, such as the uterus and bladder, are also located midline in the center of the abdomen. On the next slide, I'll go over where the major organs are located. The gastrointestinal tract is a long tube, approximately 30 feet long, within the abdomen that runs from the mouth to the anus. This includes the following internal abdominal structures: esophagus, stomach, small intestines, and large intestines. Digestion occurs in the GI tract. Assessment of the abdomen includes a thorough understanding of the functions of the anatomic structures within the abdominal cavity. So first we're going to go over ways to remember where certain structures are in the abdomen, and then we're going to discuss their functions. So this is how I remember where things are. I will put my fingers on the bottom right of my abdomen, just on the top of my pelvic bone there. And I will say, right up here is my liver. That reminds me that that's where the ascending colon is, and my liver is on the right side of my abdomen. Right up here is my liver. That also reminds me that the appendix is in the right lower quadrant, where the small intestines ends. Then I go across with where the transverse colon is, and I think about what organs are at the top that sit on top of the stomach or the transverse colon. And first, the liver and the gallbladder work together, so they're very close together. And you can see where the gallbladder is right there and hangs a little bit below the liver and nestles on top of the stomach. Then right under that arrow is the pancreas. Okay, so then we have the stomach. Now the stomach, that's the fundus of the stomach right there where the arrow is, okay? And then the stomach empties over there by the gallbladder. Then you have the descending colon. And that, at the beginning of that arrow, is where the spleen is. And then you have the descending colon that goes into the sigmoid colon and the rectum. So that's how I remember where the structures are in the abdomen. Right up here's the liver, then across with the transverse colon, and then down with the descending colon. All right, the liver metabolizes fats and carbohydrates, removes toxins, and produces bile. antibodies, albumin, and blood coagulants. The gallbladder concentrates and stores bile. So the body can actually function without a gallbladder because really it just stores and concentrates the bile, but it does function better to break down fats with a gallbladder. The pancreas produces insulin, glucagon, and digestive juices. The kidneys, ureters, and bladder rid the body of water-soluble waste, and these lie behind the GI tract. The GI tract is responsible for ingestion, digestion, absorption, and elimination. So let's cover subjective data, and this is pages 534 through page 538. This includes a review of system and covers appetite, dysphagia with a G refers to the GI tract. Dysphagia with an S is speech. Speech. So dysphagia with a G is gut or GI tract. Dysphagia with an S is speech. And dysphagia is just difficulty eating or swallowing. Food intolerances, you want to ask about food intolerances. Abdominal pain, using old carts. Nausea and vomiting, using old carts. Bowel habits, past abdominal history, medications, and a nutrition assessment. These are all concepts included within the subjective data or review of systems. In older adults, you want to specifically ask about functional assessment related to diet and nutrition. How do they get their food? Can they go grocery shopping? Can they drive to get their food? Do they have it delivered? Do they have enough money to get food? Do they cook or do they have meals delivered? Or do they just eat ready-made foods? Do they eat alone? Because we know that eating in a lot of cultures is a social endeavor, and eating alone can sometimes cause a decrease in appetite or decrease in intake. A 24-hour diet recall is important, but sometimes is not enough information, especially for older adults. And then you want to explore their bowel habits. Remember, one of the normal changes of aging is slowing of the GI motility, and this can lead to constipation. Or not necessarily constipation, because let's define constipation really quick. Constipation is a change in the bowel habits where somebody's not having bowel movements as frequently, and stool is difficult to pass and is hard and dry. So some people will think that if they've not had a bowel movement in 48 hours, they're constipated. But remember, that has to be a change, and it also has to be difficult to pass and hard and dry. Also, bowel habits can change related to amount of food that's being taken in. So if an older adult is not eating as much, then they will have a change in their bowel habits too. Also, you need to check about are they using anything to make their bowels move. I know that in my experience, and you'll see this in older adults, is they will start taking medications to laxatives to make them have bowel movements daily or at least every other day, because they think that that's a normal. But again, you have to think about what's going on with the person, their age, their intake, that kind of thing. So the patient's subjective history of their present illness should be addressed. The nurse should ask questions related to current abdominal, urinary, and bowel elimination symptoms, and current medications and home remedies. The nurse should also ask about associated symptoms. Remember, we talk about onset, location, duration, characteristics, accompanying manifestations, relieving and aggravating, and treatment. That's our old cart, okay? And we need to explore abdominal pain, indigestion, nausea, vomiting, dysuria, frequency of urination, diarrhea, and constipation. And this is on page 534 of your textbook. So let's talk about how we would explore a chief complaint of abdominal pain. This is on page 534 in your textbook. Remember when we talked about pain back in the first week of class, we talked about a visceral kind of pain. And this usually comes from larger encapsulated organs where the capsule can be stretched by inflammation or compressed by mass effects. This is visceral pain is dull and generalized, and a lot of times if you ask the patient to point to it, they can't point to it. They'll kind of circle a general area, or they'll say it kind of feels all over. Okay, parietal type pain comes from inflammation of the peritoneum, and that is the layer of tissue that encloses the membrane that encloses the abdominal cavity. And it's sharp and localized and is aggravated by movement. We're also going to talk about referred pain, and this is pain that comes from one site and can radiate or is felt in another site. And I have a slide on that in the next slide. Okay, we're going to talk about that on the next slide. Acute pain can sometimes indicate gas or constipation, but it can also indicate an emergent situation. Acute abdominal pain, especially parietal, where they can point to the specific area of pain, accompanied by a rigid board-like abdomen and obvious distress, usually indicates an emergency. And this is called an acute abdomen and can be caused by a perforation, cholecystitis, or appendicitis. So with abdominal pain, you want to do your old carts, okay? With abdominal pain, you also want them to point to where it hurts. And is it in one spot, or do they feel pain in other spots? And then accompanying symptoms is, when was your last bowel movement? Was it normal, and what did it look like? Does eating make the pain worse? How long after you eat? And do you have an appetite? And is pain associated with your menstrual cycle for females? So referred pain, you have this table on, there's a table 22.3 in your book, and referred pain is pain that results from a organ but is felt someplace else. So a classic one we'll look at is the gallbladder, okay, right here. The gallbladder can be referred to over here. Okay, so gallbladder pain a lot of times is referred to the right shoulder and into the right scapula. Okay, but they'll also feel it here where we know the gallbladder is. Okay, so the liver pain, you'll usually feel liver pain in it where we know the liver is, but also you can feel it in the shoulder. So that's just an example of referred pain. Now, if somebody has indigestion, you want to explore the onset and duration. When did the indigestion start, and how long have you had indigestion? When does the indigestion occur? Does it occur in the morning or at night, before or after meals, or do you have it all day? You want to explore the character of it. Can you describe what you're feeling? Is it fullness? Does it feel like heartburn? Is it just a general discomfort? Do you have excessive belching, also called eructation? Flatulence, loss of appetite, or is the pain really severe and limits your activities of daily living? Is the indigestion localized or general? Does it radiate to your arm or shoulder? Because if it radiates to your arm or shoulder, you know, that might be heart pain as opposed to indigestion. Does anything help relieve the indigestion? And do you take any kind of medications at home? Accompanying symptoms include gas, nausea. What kind of foods are related to the indigestion? Are there any changes in bowel habits? And again, pain. Do you have pain associated with the indigestion that's not the same as? Because a lot of times indigestion occurs in the epigastric area or in the abdominal area. So is there pain in other areas too? Like the shoulder, because if somebody's having indigestion and they tell you they're having kind of epigastric pain or right kind of epigastric pain, and they're also having that shoulder and scapular pain, that might mean gallbladder as opposed to gas or peptic ulcer disease. All right, so vomiting, when you talk to somebody about vomiting, you want to know how long have they been having it. Because somebody who has vomiting for 24 hours or less, but they're having constant vomiting, then they're vomiting up a lot of acid and they might be having some problems with alkalosis. But if somebody's been vomiting for more than 24 hours and they're starting to break down fats and proteins for energy, then they might be having an acidosis. Right, so you need to know how long it's been going on. So you want to do all that old cart stuff on set. What does it look like? Is it undigested food? Is it just bile? Is it yellow? Does it have, is it coffee ground looking? Because if it's coffee ground, then that's partially digested blood. If it's bright red blood, then that usually indicates a more rapid bleed than undigested blood. Does anything provoke it? Do certain smells provoke it? Does eating provoke it? That kind of stuff. Does standing up provoke it? Did you hit your head? And now, that kind of information is really important to gather about vomiting. And of course, when was the first day of your last menstrual period for females? And then you also want to explore what did they eat in the last 24 hours and where? Have they recently traveled? And is anyone else sick? That tells you if it's could be contagious or something that can be passed along, or if it's food poisoning or something that was gotten from food. Okay, so that's important to explore as well. Now, objective data is on page 538 to 544. Make sure you focus on the assessment skills and data that we talk about here, and not on any of the advanced practice. And remember, again, our assessments do not include pregnant women and children or infants. So, objective data, when we collect our objective data for the abdominal assessment, the order that we do things is different than any other place, okay? And we're going to talk a little bit about that. First, we inspect, which is normal. We inspect in other systems as well, but then we auscultate. Usually we inspect, percuss, palpate, and auscultate, and then auscultation is last, right? The reason that we do auscultation immediately after inspection is because if we put our hands on somebody's abdomen and percuss and palpate, we can actually stimulate peristalsis. But also, if a patient is having tenderness or pain and we go in and touch them, then they can have guarding, and it can be difficult to complete the assessment. So, for physical assessment of abdomen, we inspect and then auscultate, then percuss, and we're only percussing for dullness and tympany. We're not percussing for organ location. That is an advanced practice technique. And then we palpate, light palpation only for tenderness and distension. All right, so preparation and positioning. This is on page 538. Make sure that your patient's bladder is empty, because if you palpate somebody who has a full bladder and poor bladder control, they might have some leakage or be uncomfortable. Also, somebody who has a full bladder might guard more, and you won't be able to do a good palpation or percussion. Plus, percussing a full bladder gives a different sound. So you want to lay them supine on their back with their head slightly elevated and their knees bent to relax their abdomen. And sometimes you'll have people who will involuntarily guard their abdomen or tense up their abdomen. So you want to help them relax their abdominal muscles by distracting them, have them think about their relaxation place, like the beach or the mountains. You can have them practice deep breathing and then palpate when they're exhaling. Or also engage them in conversation. Sometimes it's a good time to complete your review of systems or ask more questions while you're doing palpation of the abdomen. Now, inspection is covered on page 538 to 541. So first you're going to stand by the side of the patient and look down, and then you're going to bend over and look across, and you can use a pen light to use some oblique lighting to highlight pulsation or other abnormalities in the abdominal shape or symmetry. You want to look for contour and distension, and you want to assess movements, including respiratory movements that occur with respirations, and if you can see any peristalsis or pulsations. In thin females who don't have thick abdominal muscles, you can frequently see pulsations of the aorta right there below the xiphoid process, okay, in that epigastric region. That is completely normal. You can best see them by standing at the foot with their legs flat, which tightens up that, pulls the abdomen taut, and you can see the pulsation by looking from the foot of the exam table up or from the side using that oblique lighting. You want to note the surface characteristics, color, hair distribution, if there's any lesions, including nevi, maculas, papulas, moles, stuff like that. Masses, if there's any scars or if there's striae. Striae can be stretch marks from being pregnant or from being overweight and losing weight, or striae can also be a sign of Cushing's disease. Okay, and then you also want to check the umbilicus or the belly button for position, shape, color, inflammation, discharge, or masses. Now here are some common shapes of the abdomens that you'll see, and you can use these in notes to describe. There's the flat abdomen. Scaphoid is where it's indented, that's the top right, or concave. You can have a slightly rounded abdomen, which is normal, especially for females, or you can have a protuberant abdomen, which could be caused by ascites, which is fluid in the abdominal cavity, obesity, or pregnancy. So auscultation is covered on page 541, and but the bedside nurse, we don't necessarily click it, count the number of clicks, but we do want to know if the bowel sounds are normal, which is at least 5 and no more than 34 clicks per minute or noises per minute. Hyperactive is more than 34 per minute and hypoactive is less than 5 per minute. You cannot say absent bowel sounds unless you have listened for a full 5 minutes. Okay. In general, we listen in the right lower quadrant, and if we hear bowel sounds, then we say that they have normal bowel sounds, hyperactive, or hypoactive. If you have a patient who has a GI issue or complaint, then you should listen in all 4 quadrants. For the head-to-toe assessment, we want you to listen in all 4 quadrants, but just tell us if it's normal, hyperactive, or hypoactive. Percussion. Percussion is used to assess for fluid, air, organs, and masses. For the bedside nurse, we're only going to assess for tympany or dullness. We're not going to percuss to locate organs. Okay, we should hear tympany, which is a hollow drum-like sound over the majority of the abdomen. You will hear dullness. If you want to see what the difference is between dullness and tympany, you can percuss over over like where your stomach is, or over the large intestines or small intestines, and that's tympany. But then move up to just below the rib cage in the right upper quadrant and percuss, and that's dullness, and that's where your liver is. So you can assess the difference in noises that way, the sounds that way, but we're just looking for tympany or dullness. If you have a patient who has a very distended abdomen and you percuss it and it's dull, that could be caused by adipose tissue or by fluid. Okay, it's not really all that great of a diagnostic differential between adipose tissue or fluid, but it is a good diagnostic for between air and fluid or adipose tissue. Oops. All right, so palpation is on page 544. We do light palpation only. We are not going to do deep palpation to try to identify organs. We're not going to hook anybody's liver. So light palpation only, and palpation, the way that you perform palpation is you put your fingers in the middle of the quadrant where you're trying to palpate, and you do it, leaving your fingers down, you do a slight circular motion. Okay, and you move it around, and you're not doing it deeply. And this can be used to assess tenderness or distension, to differentiate between obesity versus having a distended abdomen. Obesity feels a little bit different than distension due to fluid or gas. Now, if the patient has a complaint of abdominal pain, you want to palpate that area last. If there's no complaint of abdominal pain, in general, we start in the right lower quadrant and move clockwise. Okay, so now let's take a look at key abnormal findings. Now, make sure that you review your book, page 539 to 540, because we're going to talk just a little bit about some of the ones that are more interesting or that we see more frequently. Okay, so pulsations, and we already talked about the idea that pulsations can be normal, especially for thin women with I don't want to say overdone, without six packs, just with regular abdominal musculature. Okay. However, if you see pulsations, that could be an aneurysm. That could also be, instead of it could be an aneurysm. It could be a vascular issue. Okay. Asymmetry or bulges, and this is a picture on the top left. That is actually a hernia. And a hernia is when you have a weakness in the muscle wall in the abdomen, and because we're talking about abdomen here, and you have bulging of the abdominal contents through that weakness. Okay, so this guy has a fairly large hernia. Now hernias can be reducible, where you can just push it back in, or irreducible, and that can cause a strangulation, which is a medical emergency, because it's going to incarcerate the abdominal contents there and cause some ischemic injury, and even can cause infarction. Okay, you can have bulges related to surgical hernias, incisional hernias, or you can have bulges related to tumors. So you need to take a look at that. Now, striae is just below that hernia, it's the bottom left. Striae, again, can be associated with pregnancy or weight loss, but can also be a manifestation or sign of Cushing's disease. You can also have visible peristalsis, and visible peristalsis usually occurs with bowel obstructions, and you can see the movement of the intestines usually in one area, not across the whole abdominal area, like in one quadrant or in two adjacent quadrants. Now, on the far right of this slide, this is ascites, and this is a distended abdomen, and this guy is full of fluid. And if he was laying flat, you could tell he was full of fluid because the fluid would actually kind of fall to the sides, and his abdomen would kind of droop on the lateral sides, like over his hips and over his rib cage there. Characteristic of ascites is the visibility of the venous system. So you can see on this guy here, all of his veins. They're very distended, and like here you can see the veins are very distended here. Okay, and you can see that there's a slight bulge over here, and that this hangs very low with kind of a point on it. That's characteristic of ascites, and that is an overwhelming amount of fluid in the abdominal cavity, and is not really associated with the obesity or pregnancy. That's a fluid buildup in the abdomen, and that's frequently associated with liver disease and loss of oncotic or osmotic pressure due to hypoalbuminemia, or decreased protein in the blood. So liver disease relating causing portal hypertension or hypoalbuminemia. All right. So when you auscultate, key abnormal findings could be hyperactive or hypoactive bowel sounds. Remember, hyperactive is more than 34 sounds in a minute. This can be related to hyperperistalsis, which could be normal if your stomach's growling. That's also called borborygmus. It could be also associated with rapid transit and diarrhea associated with a gastroenteritis. You could also have hyperactive bowel sounds and early bowel obstruction. And a lot of times that would be, again, early bowel obstruction. And you can't really differentiate that at that point between hyperperistalsis and the idea that it's a bowel obstruction. Hypoactive bowel sounds can be associated with constipation, inflammation, like an acute abdomen, or appendicitis, a paralytic ileus, which is where the gut is paralyzed because of a nerve issue, or a muscle issue, not a mechanical issue like a mass effect or a torsion or something like that. Hypoactive bowel sounds can also be a sign of late bowel obstruction. Hypoactive bowel sounds can also be related to anesthesia or status post-abdominal surgery, where they've gone in and they moved the abdominal contents around, the gut around, and that kind of shocks them into not moving. Okay, so, and that can last usually 24 to 48 hours after surgery. Now, mixed, where you have a combination of hypo and hyper, where it's hypoactive in one area but hyperactive in another area, is a sign of an obstruction or blockage. So, dullness, this is related to percussion, and this is on page 542. Dullness can be normal and can be related to stool, a distended bladder, which are normal findings, but it can also be related to fluid or mass. Okay, hyperresonance, where it's a very high-pitched drum sound, is usually associated with gas and gaseous kind of distension. All right, with light palpation, remember you want to examine any areas of pain or tenderness last. If you have a patient that when you palpate it, their abdomen is very rigid and it can't relax, that might be a sign of inflammation. It's called rigid or board-like abdomen, usually associated by a lot of distress and a lot of pain. Tenderness in local areas can be associated with inflammation, like people who have diverticulitis, which is an inflammation of an outpouching in the large intestines. That can be a very localized kind of tenderness, and that can be related to an inflammation. You can also have infection, but tenderness can also be related to gas. All right, so some common GI problems that you will come across in the hospital or with patients include gastroesophageal reflux disease. And this is an anatomic or functional problem with the lower esophageal sphincter, and you can't really see this. Okay, so it's mostly subjective findings, and then they have to do some kind of x-ray or other testing to really do a differential diagnosis or really diagnose gastroesophageal reflux disease. So a patient might complain of burping or flatus, dysphagia or difficulty swallowing while eating, epigastric pain that occurs after eating. Remember, epigastric pain is right there below the xiphoid process in the middle of the stomach. And the pain is relieved by upright positioning and gets worse by lying down or bending over. They may also have reflux that again occurs more frequently while lying down or bending over, and it can be gastric or duodenal contents, not symptoms. I apologize for that typo there. And these symptoms occur 4 or 5 times a week. The symptoms also tend to occur with certain types of foods, like spicy foods or high-fat foods, or with overeating. Now, gastroenteritis is an inflammation of the GI tract frequently caused by bacteria or viruses, and sometimes caused by parasites. Subjective data includes cramping, abdominal pain, diarrhea, nausea, and vomiting. And the patient can report the diarrhea and vomiting to you, but if you see it, then it becomes an objective data. Okay? And objective data really depends on the length of time that they've had the gastroenteritis. They can be dehydrated, and the level of dehydration depends on the length of time they've had it. They can have fluid and electrolyte and acid-base imbalances, and then you want to look at the characteristics of the stool or the emesis. Okay? And a bowel obstruction, we talked a little bit about this when we were talking about the objective and data. A bowel obstruction can be mechanical, where it's a tumor, an adhesion, a torsion, or a hernia, or a delay in transit, where it's paralysis of the gut, either nerve or muscle related, or a decreased motility. Subjective data is going to be colicky, abdominal pain, and nausea. Objective, they'll have vomiting, and at some point, if the stool backs up into the stomach, they can actually vomit stool. It will start off with high-pitched vowel sounds that are slow but then increase. And as it progresses, they will have decreasing vowel sounds. You can sometimes have visible peristalsis and distension. Now, in conclusion, remember your subjective data directs your physical assessment. Use old carts to collect that subjective data, and make sure to explore their past medical and surgical history along with their medicines. And objective data includes inspection, and remember, it's a different order than the rest of the systems. Inspection, and you're looking at contour, symmetry, umbilicus, skin, pulsation or movement, hair distribution, and demeanor of the patient. Are they comfortable or uncomfortable? Auscultation of bowel sounds. Hypoactive, hyperactive, or normal, best heard in the right lower quadrant. Percussion, and remember we're percussing for tympany or dullness. And palpation, we're palpating for distension and pain, and it's like palpation in all 4 quadrants, starting with non-tender areas first and saving the tender areas for last. And that is the end of the abdominal and GI assessment lecture. Y'all have a great day.